Okay, so session three here. So just to recap, how can mental health be improved? What is mindfulness? So we know mental health can be improved by actually getting in contact through, whether it's in a company, through your HR, accessing EAP, accessing some of the links that we've put up for, whether it be for Alcoholics Anonymous, Narcotics Anonymous, or any of the other links through your GP, EAP, or counseling services. So again, mindfulness, a lot of talk about mindfulness now today, but really it's just detaching, doing something that makes you feel better, it calms down your nervous system, your parasympathetic nervous system, whether that be going for a walk, whether that be doing some exercise or a hobby. And then of course, nutrition is all important. Having a balanced diet, we know can improve our health. So then again, here are some resources: body scan, mediation, positive psychology, and then SPARG, Q tools at the end here, rethinking stress, loads of different links. And then of course you can go on the net to access all these various links. So managing mental health at work. So the session aim is to provide learners with the knowledge and legal requirements for managing mental health in the workplace. The objectives of this session: at the end of the session, you will be able to describe the impacts of poor mental health on an individual, others, and the organization. So on the individual themselves, people directly attached to them, family members, work colleagues, and the organization. Identify key legislation, regulation, and codes of practice related to mental health in the workplace. Outline the employees' and employers' responsibilities in relation to mental health in the workplace, and describe actions an employer can take to improve mental health well-being within the workplace. So of course, this is all important now, especially post-COVID. So really understanding your role, if you're a HR or health and safety person in the workplace, and how you can help a colleague or workers within the workplace to access some of the information that we've already discussed, and then the legal requirements. So the effects on the individual, mental, such as growing and feeling of being useless; social, such as a loss of social interaction; physical, possibly caused through coping mechanisms such as overeating. That should be coping. That's a spelling mistake there. Apologies about that. What are the effects on others? Depending on the awareness of mental health issues, those without a mental health concern may be impacted by a feeling others at work are lazy. So you may be thinking that somebody who's got mental health is actually that they're lazy. An increased workload, workplace. Now, that's the effect on others. They're taking on more work because somebody is either absent or not around, or just not able to do the job. Fear for the individual safety and health, emotional and financial pressure, increased personal stress, family care that can add pressure onto somebody, sleep deprivation and depression, family, and feeling of inability to help that family member. What are the effects on the organization? So again, loss of productivity. Somebody is absent. That's going to create more work within the company. And then if you've got a number of people who are suffering with some kind of mental health condition, and other people taking up the slack, that's going to make more people stressed in the workplace. Loss of morale then within the company. There's just not a good atmosphere in the company because there's an individual or a number of individuals that are causing more stress because of their own issues then, and that's falling onto others. So we need to have a look how it actually affects the whole company or company culture. How can organizations improve mental health? Employers could produce, implement, and communicate a mental health at work plan, develop mental health awareness among employees, encourage open conversations about mental health and the support available when employees are struggling, provide their employees with good working conditions, promote effective people management, routinely monitor employee mental health and well-being. So really looking at the company, looking at the culture in the company, and looking and promoting good mental health. That could be having like a mental health day. It could also be organizing and sending out emails about you know, mental health and the accessing EAP, the services that are there for your staff. Mental well-being focused business, getting senior leaders on board, raising awareness of mental well-being, induction training. So yeah, an induction training day, mental health days, events, internal communication channels, mental health champions, involve staff in change, staff surveys and feedback, staff forums and away days. Encourage work-life balance and improve levels of communication. So again, what would be really good is social activities in the company, as we all know. Maybe organizing a day out, a team's work day, where you're doing events, and it can be like a sports day, or it can be just like escape room or something that gets the whole group together. How to reduce stigma in the workplace policies, education, and supportive culture. So as we said at the beginning, it's really not encouraging language around somebody is finding has a mental health issue, and not using terminology like they're off the rocker or they're crackers, or just demeaning language in any way. Mental health conversation to provide learners with knowledge, skills, and attitude to be able to undertake a mental health conversation. Objectives will be, by the end of the session, the learner will be able to explain the importance of empathy when having a mental health conversation, identifying contributing factors to having effective mental health conversations. So yeah, I mean, always the conversation as much as possible, an open-ended conversation which is empathetic and trying to understand what is going on in that person's life. Give examples of open and closed questioning, describe what is meant by active listening, outline the importance of environment when having mental health conversation, outline an approach to take when supporting an individual with mental health crisis. So what is empathy? This is the capacity to understand or feel what another person is experiencing or going through as a frame of reference. That is the capacity to place oneself in another person's position or shoes effectively. So to try and understand what they're going through. And if you've ever experienced somebody who's very empathetic, they put themselves in your shoes, and they're very much trying to understand and listen to what you're saying. Keys to a really good communicator. So what is effective communication? Open body language, tone of voice, not abrupt, but low tone of voice, giving the person a chance to speak. Choice of words are very important. Open questioning, not closed questioning. So you're opening the questioning. You're not really trying to tell them what they're feeling or jumping ahead. You're listening to them with an open question and giving them a chance to respond. Active listening, empathy, and then in a nice environment where they can open up one-to-one conversation. Body language is 55%, open body language, tone of voice 38%, and then the words used are 7%. So this is what's effective when you're dealing with somebody with mental health issue or condition. This is effective communication. Open questions. Open questions require an open response, a sentence or more. Not a rambling, big, long conversation, but just a short question. How are you today? And then, how are you feeling? Let them talk. Closed questions. Open questions require a closed response, possibly just one word. Are you feeling down? Yes or no? And then let them elaborate. So open or closed again. How are you feeling today? Can you explain how that made you feel? Can you tell me about the last visit you had to the doctor? How are you feeling today? Fine. That's closed. Can you explain how that made you feel? First I was upset, but then I realized that this wasn't my fault. Open. So they're starting to open up, and they're becoming a broader conversation. Can you tell me about the last visit to the doctor? It was okay, but she said I need to keep up the medication. Open. So if somebody gives you a closed answer like fine, it suggests that they don't really want to bring the conversation on or at that moment in time. So you might ask them a more closed question. So are you feeling down, to try and get them to open the questioning a bit more. So note at the bottom, the type of question asked is either open or closed. The response and whether it's open or closed response is then the choice of the respondent. So that's based on what this person says to you. Active listening. So you want to maintain good eye contact, have open body language. You don't fold your arms. Leaning in general shows more interest. Listening to the individual. Appropriate facial expressions, nodding without talking, showing you're listening. Use appropriate confirmation words without interruption. Okay, recap to confirm listening and understanding. I heard you say that made you upset. So repeating what they say shows that you actually understand what they're saying and that you're listening to them and that you're tuning into what they're trying to get across. Environment. Consider an environment where the individual will be comfortable. Is the workplace the most appropriate place? Try to select a location with minimal disruptions and distractions. Confirm the location with the individual. So it may be a case that you need to go to the canteen, or you may need to walk across to the coffee shop to have a conversation with somebody where it's a bit more appropriate and they can feel like they can speak. Supporting that individual by having a good environment, effective communication, being empathetic, and then engaging with them. So that's all the keys to engaging with communication with this individual or individuals. So just to recap through all of this, and you can actually go through this in your workbook, which will be accompanying this, is what is empathy? It's somebody who's an effective communicator and is listening. Why is empathy important when having a mental health conversation? Because we want the person to be empathetic, listening to you, giving open and closed questioning, which will help the individual open up. What are contributing factors to having effective mental health conversation? So it's being empathetic, good communication, a good environment where you can speak to the person, and then body language is all important. Relaxed, nodding, not folding your arms. And then giving examples of open and closed questions. What is meant by active listening? Why is the environment when having a mental health conversation important? As we just said, it wants to be a relaxed environment and not where other people are coming in and out, where that person can't open up and tell you what they feel. What is an approach to take when supporting an individual in a mental health crisis? So, action plan is found at this link here, www.mentalhealthfirstaid.org. Psychosis. On completion of this session, you will be able to define the term psychosis. Identify factors that increase the risk of an individual developing psychosis. Outline ways to identify an individual who has psychosis, and list organizations where individuals with psychosis can be referred. So as the spectrum goes, this is at the higher end. So you are less likely, obviously, to come across this, but again, we need to have an understanding of this and an outline of it. So psychosis is a mental condition where sufferers comprehend or interpret reality differently from those around them. So completely different understanding. They may see, hallucinate, and hear things. So it's a really at the far end of the spectrum of mental health conditions. Hallucinations, delusions. Risk factors would be schizophrenia, bipolar disorder, paranoia, severe depression, or mania. Other contributing factors may include a family history of psychosis, experiencing abuse or trauma, or suffering a bereavement in the family. So these can lead on. Risk factors, in addition to psychotic hallucinations, can also be caused by the following: taking certain drugs such as LSD or using cannabis, alcohol misuse, taking certain prescribed drugs such as those for depression or mood swings, a severe and prolonged lack of sleep, being extremely hungry and having a high temperature, fever, head injury, or brain tumor. Okay, so Just coming back to psychosis risk factors. Psychosis can also be recognized by the following symptoms: losing touch with reality, being unable to tell the difference between perceived reality and reality, a severe change in behavior, confusion, disturbed thoughts, disturbed speech, or quickly moving from one topic of conversation to another, little or no self-awareness that some things aren't real, leading to fear and uncertainty. Assistance for people suffering psychosis. So obviously GP being the first role of access. And even if they refer to EAP, I think anybody with delusions or, hallucinations will be sent first to a GP and very quickly then to a mental health service. So this is St. Patrick's Mental Health Services here, and this is the number for them. So basically psychosis is where somebody's at the far end of the spectrum. We don't see it as often, and it is somebody who hallucinates and is delusional and doesn't have a grip on reality. Risk factors that increase the risk of an individual developing psychosis. Of course, it may be genetic. There may be a trauma that may have led to it. Or a chemical imbalance in the brain. Signs and symptoms of an individual who has psychosis, again, is delusional, hallucination, confused, very poor self-awareness. And what organizations can individuals with psychosis be referred to? First port of call, again, would be a GP. Personality disorders. So on completion of this module, you'll be able to define the term personality disorder, identify the different personality disorders, identify factors that increase the risk of an individual developing a personality disorder, describe ways to identify an individual who has same, and list organizations where an individual personality with a personality disorder can be referred to. So somebody with a personality disorder, they have difficulty, a difficulty in how an individual thinks about themselves, others, and the world to a degree where normal daily life is affected. So again, these are all on a spectrum, and sometimes they can find interlope. Somebody with a personality disorder, somebody might think that they're psychotic, but it's not. They might have what we call disassociation, and they're not sure that they are in touch with reality. They don't necessarily have hallucinations like psychosis, but they just, again, feel like they may be losing their mind or not in touch with reality. So paranoid PD, personality disorder. Schizotypal personality disorder, which again is like on the spectrum of schizophrenia. Borderline personality disorder. Narcissistic, dependent, schizoid, antisocial, histrionic, avoidant, and obsessive compulsive. So they're all like a branch. They're all cousins of one another, if you like, of personality disorder. Some more extreme: paranoid, schizophrenia, and then something like OCD. So contributing factors to personality disorder: early childhood environment would be huge. What they say is first 7 years is very important. Behavior management, physical abuse, sexual abuse, violence, either directly or within the family unit, and having parents who abused alcohol. So these are all the contributing factors to that. Again, you got assistance, again, GP, and then mental health services, St. Patrick's, again, would give great support and information. Bipolar disorder. So bipolar disorder is where an individual may show mood traits that range from being manic one day to depressed the next. A person with this condition was often referred to as a manic depressive. So that was the old terminology. Somebody who's up and then somebody who is down. Stephen Fry, the author, comedian, and actor, was somebody who was described as bipolar or manic depressive. Very often they take medication, something like lithium, to keep them balanced, but there's many different drugs, many different counseling services as well that they would obviously be taking, be given. Contributing factors to bipolar disorder. Again, the cause is unknown. They're not sure. It can be chemical imbalance. Genetics can contribute. Stressful situations trigger a lot of these disorders. Bereavement, relationship breakdowns, abuse, and other overwhelming day-to-day concerns. The signs of symptom, when they're in the mania stage, it can be recognized by euphoria, high energy levels, lack of concentration, talking quickly, restlessness, and then risky behavior. Depression recognition, this is then obviously when they're on a downer, continuous low mood or sadness, feeling anxious or worried, feeling irritable or intolerant, feelings of guilt, feelings of hopelessness, helplessness, and then finding it difficult to make any kind of decision. Assistance for bipolar disorder, the person should see their GP. And when supporting individual with bipolar disorder, it is important to remember that the emotions they are showing are based on their current feelings at the time. So, you know, if they're high, they're probably not going to be seeing anybody. When they're low, they're in that low mood and they need help for those depressive and guilt feelings and intolerant feelings and just unable to make a decision and feeling very worried and down and panicky. Try not to be confused when an individual's mood seems to change frequently. Remember, if they are not sleeping, this will affect their attention and engagement. Remember also that the depression side of bipolar disorder can be very dark. In some studies, around 15% of the individual bipolar disorder will complete suicide. So that's the problem with it. You know, when they're on a real downer, life isn't worth living, and they get so low that they can very often commit suicide and kill themselves. So, yeah, so trying to recognize this and point them in the right direction is what we want to do. Again, at the higher end of the spectrum, or percentages that we see less of, is schizophrenia. Schizophrenia is a serious mental disorder in which people interpret reality abnormally. Schizophrenia may result in some combination of hallucinations, delusions, and extremely disordered thinking and behavior that impairs daily functioning and can be disabling. Contributing factors to how schizophrenia comes about in an individual. Again, it's unknown. We feel again it may be genetic, brain chemistry, genetics, and then certain environmental factors. For those at risk, stressful situations and some recreational drugs may trigger an episode. So yeah, they do believe that certain drugs like cannabis may cause and trigger a small percentage of people to develop schizophrenia. These studies are very hard to pin down, but this is what they are saying. Signs and symptoms of somebody that is suffering with schizophrenia: they have a lack of interest in things, feeling disconnected from their feelings, they avoid other people, they hallucinate, they have delusions, disorganized thinking and speech, self-neglect, so don't look like they're looking after themselves, don't look like they wash or dress themselves properly, strange actions during hallucinations, so it could be looking like they're actually speaking to somebody in the room and there's no one there. Again, our GP's first protocol, and then the Schizophrenia Association of Ireland. This is the link here, shine.ie, where we can get more information or point people in the right direction. So coming to legislation around mental health. So the aim of this is to give you a good understanding of the current legislation that applies to mental health and how it has changed over time. At the end of this, you'll be able to describe the legislative framework for mental health provision, summarize the changes in legislation over time, and explain how current legislation applies to people with mental health problem. Legal framework. You have the Safety in Health and Welfare Act of 2005. This covers lots and lots of stuff. And then you have the Mental Health Act of 2001, and then Employment Equality Acts from 1998 to 2015. And then you have the MHC Mental Health Code of Practice on the Use of Physical Restraint in Approved Centres 2009. What is the employer's responsibility? So as an employer, or if you're representing your employer, protect the health, safety, and well-being of employees and to assess the risk to this and implement reasonably practical solutions. So very much to protect your employees and obviously taking that into account, all employees. So the stress and strain that is on put on other employees when one or two employees are sick or suffering from a mental condition, i.e., people are then going to have to take on more work, etc. So it's looking at the effects of all of this on the whole company. Human Rights Act from 2003. This is the right to life, not to be subjected or torture or to inhumane or degrading treatment or punishment. Personal liberties, freedom of expression, the right to fair procedures, bodily integrity, religious liberty, and privacy. So these are what come under the Human Rights Act. These are basic fundamental rights for every individual. The Mental Health Act of 2001. This is the best interest of a person, most important thing to consider. Right to information in relation to involuntary detaining a person, right to review of their detention by a solicitor, psychiatrist, layperson. The highest standards of care must be provided. Established mental health commission. So this is just, with somebody who has got mental health, the role of the Mental Health Act is to protect the person, but and how that is done by the right to review of their detention. So if they needed a solicitor, a psychiatrist, a layperson, they would be involved if the person needed to be detained. But within that framework, they're given the highest standard of care. The main change to legislation. A vision of change details a comprehensive model of mental health service provision for Ireland. It describes a framework for building and fostering positive mental health across the entire community and for providing accessible community-based specialist services for people with mental illness. The impact of legislation on mental health services. This has put a strong emphasis on the importance of working towards recovery. A vision for change also embraces a biopsychosocial model, which means that mental health problems are a result of complex interactions between biological, psychological, and social factors. So we look at mental health as how it affects the person physically, mentally, and socially. And then the whole idea is to try and deal with those individually and collectively, and then return them to society as a fully functioning individual. The involvement of service users and their carers in the service development, better links between mental health services, primary care, voluntary and mental health groups were other key recommendations. In essence, this has come a long way in the last 100 years. We have such good mental health services. It is overloaded now post-pandemic, which was already flagged by many health experts. But it's from Dickensian times, it's a long way from somebody just being thrown in a padded cell, as it were. And now there's lots of services that they can access. But there is quite a waiting list. So first protocols go through the GP. The relevance of legislation to people with mental health problems, advocacy, family, stakeholder, individual, a person-centered care, suitability of service, the individual leads their care pathway, safeguarding, ensuring safe quality service, well-being, emphasis on the importance of working towards recovery for the individual. So that's the relevance of legislation to people with mental health problems. The involvement of mental health services. This is the evolution from institutional care to community-based care. So as I just said a few minutes ago, 100 years ago, it was very different. It was institutional care. People who were put into an institution very often would be there for years and they may never come out. Now they have a whole encompassing treatment plan, mental, physical, social, and it's community-based. So a lot of these will have local community-based care with the whole idea of getting the person back, living with their family, living in society. A report in 1966 recommended that hospitals for the mentally ill needed to change to a more community-based service. So in 1984, a report, the Psychiatric Services Planning for the Future, was developed. Operational framework for developing psychiatric services, a community-oriented service which was both based, integrated within the community, a better understanding for caring of people with mental illness. A community-orientated service should not result in a break with the patient's family, work, and other social commitments. So the family can access them, their friends can get to them, and they can still access social hobbies and commitments that they want to get involved with. And that can bring them obviously out of their mental health condition and rehabilitate them. The level of help and understanding shown to the mentally ill by their family, friends, and workmates have a great influence on their recovery. So recapping, I'm not going to go through it again, but legislative framework, you can go through that there. Mental health service provision. The main changes in the legislation we've just spoken about changing in the last 100 years. And in 1966, the framework was decided we need to change how we deal with people with mental health illnesses. In 1984, a framework was put into a more community-based approach to mental health. Attitudes and perceptions of mental health. To provide you an understanding the range of attitudes and perceptions of mental ill health, on completion of the module, you'll be able to summarize the public attitudes and perceptions of mental health have changed, describe how the media can influence attitudes and perception of people with mental health problems, and explore how cultural perceptions of those mental health problems may vary. Describe how public perception may affect those with mental health problems. So what are the changes to mental health? Media coverage, news, crime dramas, public campaigns, these have all changed. Cultural attitudes towards individuals are treated. Reason for this change: reduce isolation, reduce stigma, and support inclusion. So when we educate people and say, you know, this person has bipolar disorder or they suffer with panic disorder, it puts a name on it, and without labeling it, it just, rather than just saying the person is crazy or nuts or, you know, they've got mental problems, but it defines it, and then it educates people then as well. And that's, the media are very involved, obviously, in doing that now, and media coverage and public campaigns are very good for doing that. And it changes then the culture within society. It normalizes mental health issues. Media influence public perceptions. How can they do it? Through TV, film, news, and social media. The effects of media, positive and negative. Obviously, there's always a positive and negative. Certain mental health conditions are wrongfully portrayed. Trivialized mental health issues, suffering from mental health issues could become trendy. Awareness campaigns don't always mean education. Public understanding of the biological correlates of mental illness seems not to result in better social acceptance of persons with mental illness. So really, you know, as I say, positive and negative, we don't want to trivialize people's mental health issues, but we want to educate people on them. So that's a key role that media can play in it, and social media. But there's not always, especially social media, Facebook, etc. It can dramatize some things, and it can put good information out there as well. The effect of public perception on sufferers. So commonly perceived people with schizophrenia, alcoholism, and drug addiction. So schizophrenia at one time, where you just thought somebody was so dangerous they were going to run up and stab you or kill you because they were crazy. And that's a tiny percentage of people who suffer with schizophrenia are like that. It's more the case that they are delusional and they have a lot of hallucinations. So, you know, seeing them as unpredictable and dangerous contribute to social isolation, distress, difficulties in employment faced by sufferers. So then, you know, we're basically, you know, putting out there that these people are not employable and cannot be in society, and that's because of misinterpretation of really what their mental health condition is. Are you aware of people who have spoken out? Can you give examples of people who have spoken out? What have they talked about? So have a think about that. Are you aware of people who have spoken out? Can you give examples of people who have spoken out and what they've talked about? And then again, in the media and TV, sometimes you'll see an interview with somebody and they talk about their mental health issue. And it's really good because it gives their perspective on it. And somebody else may be watching and think, you know, well, that's me. I suffer with that as well. So again, we just to recap, public attitudes and perceptions of mental health, how they've changed, how media can influence attitudes, perceptions of people with mental health problems. Cultural perceptions of those with mental health problems vary, and describe how public perception may affect those with mental health problems. Okay, so the current framework of services available: child and adolescent mental health services, general adult mental health services, psychiatry of old age mental health services, child and adolescent acute inpatient services, and adult acute inpatient mental health services. Designated centres: how an involuntary admission happens. So this is involuntary admission for somebody. A concerned person applies to the medical professional to have you assessed. This is usually done by a GP. The concerned person must have seen you in the last 48 hours. This concerned person must be over 18 and one of the following: a relative or spouse, an authorised officer who is an employee of the HSE, a member of the Gardaí, a concerned member of the public, or any other concerned person. The medical professional must examine you within 24 hours of getting the application. They may recommend that you're admitted to hospital. A consultant psychiatrist in the hospital will examine you then also within the 24 hours. And if they decide you need to be admitted, you're not willing to stay, you'll be admitted against your will. So basically, this is involuntary admission. So the first step is you see the GP. The concerned person must be seen within 48 hours. And this also might be referred by a relative or a spouse, concerned about one of their loved ones. Based on an assessment by a psychiatrist, this person will be admitted or may be admitted against their will, depending on GP and psychiatrist's determination. So that's involuntary. Now, this is designated centres. Voluntary admission occurs in much the same way as admission to a general hospital. Referral may be held by your GP or consultant. Unlike patients in general hospital, you're not always completely free to leave psychiatric care when you wish. If you're a voluntary patient who wants to leave a psychiatric centre and the consultant psychiatrist or doctor or nurse on the staff considers that you're suffering from a mental disorder, the professional may detain you for a maximum of 24 hours, firstly. If the voluntary patient is a child and the parents of the child or guardian want to remove them, the professional may have a child detained and placed in the custody of HSE, Health Service Executive, if the professional considers that the child is suffering from some kind of mental disorder. After 24 hours, the consultant psychiatrist must then either discharge you or arrange for the examination by another consultant psychiatrist, basically to get a second opinion. The second consultant must issue a certificate stating that you should be detained because of mental disorder or may discharge you. If you are detained, then you are an involuntary patient, and all the procedures relating to information review and appeal apply in the usual way. So if you're detained now, you become involuntary. It means that you need to be, for whatever reason, the consultant may feel that you're harm to yourself or others, and then you must be detained. So these are all the independent centres in Ireland: YAP Ireland, St. Patrick's Mental Health Services, Bloomfield Mental Health Services, and then residential facilities. Changes to professional approaches. So institutionalization and exclusion to inclusion, building resilience and person-centered care. So it's more an inclusive, it's not institutionalizing, locking somebody away. It's about having community-based centres, trying to get people back into society. Decongregation of facilities, services should be recovery focused, greater knowledge on the illness and medications for family members, for colleagues and public at large. Focus on mental health in the community. Individual and stakeholder leading their recovery plan.